In this video, we talk about classification of thyroid cancers, its surgical management, how we stratify the risk, and management based on this risk stratification. Thyroid cancers are classified based on the cells they arise from. First, we have the follicular epithelial cells, which could give rise to either a differentiated or an undifferentiated thyroid cancer. These differentiated cancers could be of the papillary or follicular type, and the undifferentiated cancers are called the anaplastic thyroid cancer. The second type of thyroid cells are the parafollicular C cells, which give rise to the medullary cancer of thyroid. Surgery is the primary mode of therapy for patients with differentiated thyroid cancer. But which operative approach to take depends upon the extent of the disease, for example, the primary tumor size, presence of extrathyroidal extension or lymph node mets, the patient's age, and presence of comorbid conditions. For small tumors of size less than 1 cm and no extrathyroidal extension and absent lymph nodes, treatment of choice is lobectomy. For tumors of size 1 to 4 cm without extrathyroidal extension and no lymph nodes, we either do a lobectomy or total thyroidectomy based on the patient or doctor preference and the USG abnormalities in the contralateral lobe, for example, nodules, thyroiditis, etc. For tumors of size greater than or equal to 4 cm or tumors with extrathyroidal extension or METs, total thyroidectomy is the treatment of choice. In patients with history of head and neck radiation in childhood, total thyroidectomy is the treatment of choice, irrespective of the tumor size. For patients with multifocal papillary microcarcinoma with less than 5 foci, the treatment of choice is unilateral lobectomy and isthmusectomy, whereas when more than 5 foci are noticed, especially if the foci is greater than 8 to 9 mm in size, total thyroidectomy is preferred. So the next question arises, how do we stratify the risk in these post-operative patients? While evaluating post-op, we obtain the serum TSH and thyroglobulin levels 4 to 6 weeks after the surgery. ATA, which is the American Thyroid Association, expect the thyroglobulin levels to be less than 5 nanogram per ml after a total thyroidectomy and less than 30 nanogram per ml after a lobectomy. If values are seen above these ranges, evaluation for METs becomes necessary. The clinicopathological features are important in each case for providing prognostic information. Hence, we have the TNM staging, which is the tumor node metastasis staging system, to estimate mortality, and the ATA risk stratification system to estimate the risk of recurrence. In the TNM staging, as described by the American Joint Commission on Cancer, the stages are different for ages less than 55 and greater than 55 and depends on the tumor size, nodal involvement, and metastasis. We use the ATA initial risk stratification system to estimate the risk of persistent or recurrent disease. This system is designed to stratify patients as having either a low risk, that is papillary thyroid cancer confined to the thyroid, intermediate risk, regional METs, worrisome histologies, extrathyroidal extension or vascular invasion, or high risk in cases such as gross extrathyroidal extension, distant METs, or post-operative serum thyroglobulin suggestive of distant METs. And this is primarily based upon the clinicopathological findings seen in the post-op evaluation. On the basis of this risk stratification, post-operative thyroid hormone therapy or radioiodine therapy is initiated. For patients who have undergone lobectomy, TSH is measured 6 weeks after surgery and the need for T4 replacement depends on this TSH level. The levels between 0.5 to 2 MIU per ml is acceptable. In patients who have undergone total thyroidectomy, all patients will require thyroid hormone therapy to replace normal production as well as to suppress the regrowth of tumor. This dosage of therapy depends on the ATA risk stratification system. For patients with low-risk disease who have detectable serum thyroglobulin level, the serum TSH can initially be maintained between 0.1 and 0.5 MU per liter. Whereas for patients who have undetectable serum thyroglobulin levels, TSH is maintained between 0.5 to 2 MU per liter. In patients with intermediate risk disease, the TSH can initially be maintained between 0.1 and 0.5 MU per liter, and in high-risk patients, this is less than 0.1 MU per liter. Radioiodine therapy is administered after thyroidectomy for ablation of residual tissue or provide adjuvant therapy for metastatic disease. In patients with low-risk disease, until proven beneficial, radioiodine therapy is not administered. In intermediate risk disease, therapy is administered in those patients who have clinically significant lymph node METs, vascular invasion, or more aggressive histological subtypes. In patients with high-risk disease, radioiodine ablation is recommended in most patients. With this, we come to an end to the video on management of differentiated thyroid cancers. In the next video, we'll talk about monitoring response to therapy and management of persistent or recurrent disease. If you like this video, please like, share, and subscribe.